In the middle of the session, we have a wonderful keynote address from our guest faculty, Aure Roston. She'll be talking on managing the unhappy refractive cataract patient. All to you.
Great. Thank you so much. Thank you, sir, and thank you for the opportunity to speak here. I have no significant financial disclosures. The first thing that we need to decide is, why is the patient unhappy? Is it a quantity or a quality of vision issue? Do they have dysphotopsias? Is it decreased contrast? Is it distance vision that they're concerned about, near vision? And also the timing. Have they been unhappy since the cataract surgery, or did it happen weeks to months later? Of course, evaluating the patient, we do the usual evaluation, all the diagnostics that we normally do. You want to pay careful attention to higher order aberrations, and also do a very, very careful slit lamp exam, of course, and a very, very careful refraction. Well, why is the patient unhappy? If it's a quantity of vision issue, and this we ascertain by refracting the patient. If a simple good refraction fixes the problem, and I would say is that you actually have to do not an auto refraction, but an actual old school refraction, because auto refractions in patients, especially with multifocal IOLs, are not going to be accurate, and you're going to end up over minused. If the refraction fixes the problem, then it's really pretty straightforward. If it's greater than a diopter, I prefer IOL exchange. And if it's a small residual refractive error, less than a diopter, then PRK or LASIK is going to be your friend here to fix this. If it's an axis of astigmatism issue, then potentially a rotation of a toric IOL. So you really want to ascertain, is it a quantity versus quality? If it's a quality of vision issue, then it gets a little bit more tricky here and a little bit more in depth to decide, why is the patient unhappy with their quality of vision. If it's a negative dysphotopsia that they're describing, most of the time this improves with time. And I reassure the patient that over 90% of patients who are experiencing negative dysphotopsia, by the time they're 6 to 12 months out, they're not going to notice it anymore. And so there I just really give a tincture of time. If they are still unhappy a year later, then you can decide to do a reverse optic capture or even an IOL exchange for a 3-piece silicone lens. If it's a positive dysphotopsia, glare or halos, and if it's been present since the surgery and there has been no improvement, then an IOL exchange may be your best bet. You, of course, want to notice, is there any corneal pathology? If there's anterior basement membrane dystrophy or a corneal scar, keratoconus, then you need to address that first. And if it's floaters that are really bothering the patient, if everything else checks out and it's floaters, then you can consider a YAG vitreolysis or pars plana vitrectomy for floaterectomy. We have our toolbox here. All of these things are available to us, and you have to decide what is the best modality to treat your patient. The most important thing, though, is to listen to the patient. Decide, what is it exactly that they're complaining about? Is it the quality versus the quantity of vision? And so we'll go through some cases here, and these are actual cases. This was a 61-year-old physician, a colleague. He had LASIK way back when, little mini monovision, and came to me. We decided on an EDOF lens. I implanted the Alcon Vivity lenses, uneventful femtosecond laser surgery, a week apart. I treated pre- and post-operatively, dry eye, ocular surface, everything. Here was his vision and his refraction, and he did have some ghosting in the right eye. Looking at the tomography here, looking at the pentacam, he did have some irregular astigmatism, which was unchanged from preoperatively, and I thought, well, this must be the thing, so let's go ahead and do a Contura topo-guided PRK. So I went ahead and I did that, and yay, 20/20 in the right eye, minimal refraction, vision in the left eye, which had some myopia, was unchanged. And so here he was, 20/20, J2 at near, and you would think, congratulations, you did a good job. Well, not so fast. The patient was happy with his near vision, but he stated that with his right eye, he felt like the cataract was back. He did have significant PCO. I did a YAG capsulotomy in both eyes, and he came back 6 months later after traveling, and he was still 20 unhappy. He had 20/20 vision in the distance with both eyes, 20/20 in the right eye, 20/40 unchanged in the left, and so what to do? Well, before we get to what I did, we'll go over another quick case. Another patient, this was the mom of one of my kids' friends, a 64-year-old hyperope. You could see here, nothing too exciting there. I did uneventful surgery on her with multifocal lenses. Again, 20/20 in the distance, J1 intermediate and near, and you're thinking this is a win, so excited, congratulations, but again, not so fast. 20/20 and 20 unhappy. She said, I know that you told me I'd see some glare and halos, but I wish the cataracts were back. 4 months later, because of course they always tell you in the sales booths, oh, they just need to neuroadapt. Well, sometimes they do need to neuroadapt, but a lot of times they just don't, and they're just unhappy. And so gave her about 4 months, no neuroadaptation. Yeah, the halos were a little better, but still miserable. And so for both of these patients, what I ended up doing was an IOL exchange. I exchanged the multifocal for a light adjustable lens. I know that you don't quite have that technology, I think, or maybe you're just getting it here. But essentially, when I do my IOL exchanges, I like to cut the lens. I don't cut all the way through, I just cut partially. Oh, something going on here. Seems a little stuck. There we go. I cut partially through, and then I just twist and turn the lens out, and then, okay, it's always convenient. And then, thank you. And then remove the lens there, and then go ahead. I just want to advance the video here. And remove that lens, and then basically I'm going to implant the light adjustable lens. It goes in, it's a 3-piece lens, and it fits nicely. You can put it, the nice thing is that you can place it either in the bag or in the sulcus with optic capture. Both of those ended up 20 happy. Case 3, this is a 67-year-old gentleman who complained of blurry variable vision since surgery. You could see here he had some astigmatism, no previous ocular surgeries. And when we look at the slit lamp as well as the Penacam, we could see here that, in fact, he had a Salzmann's nodule that was causing his distress and his unhappiness. Performed a superficial keratectomy, and then 6 weeks later evaluate. You can also see this with untreated or unrecognized anterior basement membrane dystrophy. I see this actually quite often on patients referred to me. Another woman was referred. She had cataract surgery a couple of months previously and complained of terrible vision, no previous surgeries. You could see her refraction here. And of course, when we look at the imaging, we could see here that she, in fact, had unrecognized keratoconus because the referring doctor did not do a tomography or topography. And so she, of course, needed the IOL exchange. An IOL exchange is really nothing to be afraid of. They're really quite straightforward to do, and that can be actually the best thing sometimes for the patient. Of course, if you can do something else, then you don't need to do that, but they actually work quite well. So here's the algorithm for an unhappy IOL patient. If it is a quantity of vision issue, if refractive error is fixed by refraction, an IOL exchange for greater than a diopter, less than a diopter, I prefer LASIK or PRK, and sometimes you need a toric IOL rotation. If the capsule is not intact, then you could also consider PRK or LASIK in this situation. If it's a quality of vision, decide what the issue is. If it's a negative dysphotopsia, usually gentle reassurance helps, and if not, then a reverse optic capture or consider an IOL exchange. If it's a positive dysphotopsia or contrast or glare issue, you can wait a few months. If that's not changed, then exchange. And also check for other pathology. There could be unrecognized anterior basement membrane dystrophy. I see this on a fairly regular basis. Don't forget about floaters or vitreous opacities. A YAG floaterectomy or pars plana vitrectomy can also be very helpful here. And for keratoconics, an IOL exchange for either a monofocal, toric, or small aperture lens can also be helpful for you. This is my algorithm for selecting IOLs. It basically helps go through all of these different scenarios here. And at the end of the day, just like I tell my kids, it's easier to stay out of trouble than to get out of trouble. Thank you.
Thank you so much for that wonderful talk.